Hello, we're back again, and still we are on our anemia that is associated with increased red cell destruction. And specifically, on this video, we're going to discuss classification of hemolytic anemia, more specifically in the spectrum of extrinsic hemolytic anemia. So again, since it is very long, so that is why we divided our video discussion into three. But don't you worry, because it would be the last video discussion under this anemia that is associated with increased red cell destruction. So again, I am Eden, and together with my group mates, Carmel, Trisha May, Citiranisa, and Mia, we're going to share our understanding about the extrinsic hemolytic anemia. Okay, so to start, may I introduce to you our coverage for this discussion. Of course, the extrinsic hemolytic anemia, which it is divided into two, the immune-mediated and non-immune-mediated hemolytic anemia. Where under immune-mediated hemolytic anemia, we have isoimmune, autoimmune, and drug-induced. While in non-immune-mediated, we have microangiopathic, hemolytic anemia that is associated with infections and toxic agents and hypersplenism. And our reference, we base it again in our reference book, Redux Hematology 6th edition. So again, as an overview, we were going to be focusing on the extrinsic hemolytic anemia. So this one. So this part, we will going to be focusing. And again, extrinsic, so X meaning from the external factors. So the problem is not on the RBC itself, but on the outside of the RBC. So you will know it more better in our, as we discuss or as we detailed every part of it. Okay, so to start our discussion under acquired extrinsic hemolytic anemia that is associated with immune-mediated. So may I introduce to you Ms. Najmia Membantas for the isoimmune and autoimmune hemolytic anemia discussions.
Okay, let's proceed to the isoimmune hemolytic anemia. Next slide, please. Okay, in the isoimmune mediated hemolytic anemia, we have the hemolytic disease of the newborn. It is the destruction of fetal RBCs following transplacental passage of maternal anti-fetal red cell or IgG antibody resulting to the hemolytic anemia in newborns. So for this one, the main antibody for this disease is the IgG or the immunoglobulin gamma. So what happens here is that when the fetal RBC, which possess an antigen that the mother lacks, it crosses the placental of a maternal circulation. And then in that, it stimulates antibody production. And that antibody will return to the fetal or the baby's circulation and result in RBC destruction. For the cord blood findings for this disease, we have the hemoglobin is normal to decreased level kasi nga the fetal RBCs is being destructed. And then the reticulocytosis, an increased number of NRBC, erythroblastosis fetalis, and then the C, macrocytosis and polychromatophilia are prominent. Next slide. The second one is the hemolytic transfusion reactions. Destruction of red cells following blood transfusion of red cells bearing antigen not normally found to the recipient, resulting to the production of antibodies against the recipient red cells. So dito lang sa definition, it explains that this occurs after the blood transfusion. So the RBCs that was given during the transfusion is destroyed by the person's immune system. And then the common causes of HTR is the ABO antibodies having anti-A and anti-B antibodies if IgM is most potent type. Next. So the delayed reaction for this one, we have the Rh antibodies, an IgG type of antibodies that do not bind complement. For this Rh, this tells with what is protein in our RBC. So the Duffier-Kell system antibodies, an IgG type of antibodies with sublytic complement activation properties. So this one, this explains the diseases for newborns, that the antibodies of pregnant woman blood crosses the placenta and destroys the baby's red blood cells. Next slide. And then now we have the autoimmune hemolytic anemia still under the immune-mediated. Page 8. Since it is due to an altered T cell suppressor activity immune response resulting in the production of B cell antibody against the host's own RBCs with subsequent hemolysis. So this occurs when your immune system makes antibody to attack your own RBCs with the subsequent hemolysis. We have the warm antibody autoimmune mediated hemolytic anemia. So when patient immune system produce an antibody, usually immunoglobulin gamma, remember that for warm antibody, we have the immunoglobulin gamma type. So when the patient immune system produces antibodies against its own red cells, it rises up to one temperature of 37 degrees centigrade. And then for the next. And for the cold hemagglutinin disease or cold agglutinin disease, the pathologic cold, wait lang. For this one, the pathologic cold autoantibodies usually are IgM. So remember yung sa first antibody, which is warm, is IgG. And then for this one, it is IgM. The pathological autoantibodies, usually IgM antibodies against the antigen, both can activate complement C3b. Next. Just to add to the cold, and just to add information to the cold, cold disease, we have it is attacking the RBCs, trigger the cold temperature, and that usually happens for adult individuals. And for this one, the third one, it is the paroxysmal cold hemoglobinuria, but it is a very rare disorder common in females of any age. It is caused by presence of cold reacting autoantibodies in the blood and characterized by the sudden presence of hemoglobinuria. So, syempre, there's the presence of a cold reacting antibodies. Mga common symptoms nito is chills, pains, discomfort, and blood in the urine. Next. And for the drug-induced hemolytic anemia, next slide. It is immune hemolytic anemia that may occur following the administration of drugs. The mechanism that appear to mediate the immune hemolysis are the absorption of drug to red cell membrane, or the Hampton mechanism. Hampton mechanism is an immune response only when attached to a large carrier. So example is protein. And then the absorption of immune complexes, the red cell membrane, or the innocent bystander mechanism. I'm going to discuss that on the next slide. And then the induction of auto-antibody by drugs of alpha methyl-dopa, or the autoimmune unknown mechanism. And then on the next slide, we have we have here the mechanism, drug type, antibody type, DAT, or the direct antiglobulin test, and hemolysis. So kanina we've discussed about the Haften mechanism. So the Haften, the drug type for this one is penicillin. It is large doses and streptomycin and cephalothin. The antibody type is IgG, or the immunoglobulin gamma, and the DAT is positive. And the hemolysis occurs is extravascular. It is in the spleen. And then for the innocent bystander mechanism, the drug type is stabofin. It is small doses, not same with the penicillin that is large doses. And the AB type is IgM or IgG. And the DAT is positive, same with the Hapten. And then the hemolysis is intravascular, which means it occurs in the blood vessels. And then we have the alpha methyl-dopa. The drug type is methyl-dopa dose-related IgG, levodopa, L-dopa, or the mefenamic acid. The AB or the antibody type is IgG, same with the first two, but for the innocent bystander, we have IgM or IgG, and DAT for the alpha methyl-dopa mechanism is still positive, and the and 1% chance of developing hemolysis. And that's all for the immune-mediated hemolytic anemia.
Okay, in this discussion, I just want to emphasize that as what Najmiya said, that the AT means the direct antiglobulin test. So what is this test all about? So this DAT test is all about determining whether if our red blood cells that is circulating in our bloodstreams are covered with antibodies or not. So meaning if it is positive, so it means that our RBCs have antibodies that are attached with. But if it's negative, then there are no antibodies that's attached. So pag positive, so meaning merong antibodies na naka-attach sa ating red blood cells. And that attachment of antibodies, so it will lead to the destruction of our RBCs. And that is how drug-induced can be contributed into hemolytic anemia. And that's all for the immune-mediated that is still under our extrinsic hemolytic anemia. Now let's proceed to non-immune-mediated hemolytic anemia, the microangiopathic hemolytic anemia, which will be discussed by Ms. Carmel.
So hi everyone, I am going to discuss the microangiopathic hemolytic anemia. So next. So the microangiopathic hemolytic anemia, it is a hemolytic anemia with red cell fragmentation. For example, we have the schistocytes and irregularly contracted cells. And also when we say microangiopathic hemolytic anemia, this describes the anemia that results from physical damage to the red cells following the occlusion of arterioles and capillaries as a result of fibrin deposition or platelet aggregation. So below are the clinical states associated with microangiopathic hemolytic mechanism. So first we have here the hemolytic uremic syndrome. So it is caused by several O serotypes of E. coli virotoxin or by etiologic agents. So the hemolytic uremic syndrome, or the HUS, is commonly occurs in infants which are less than 2 years old, having diarrhea caused by several O serotypes of E. coli virotoxin or by etiologic agents. And Hemolytic uremic syndrome, it is a condition that affects the blood and blood vessels. So it results in the destruction of blood platelets, which are cells involved in clotting, a low red blood cell count, and kidney failure due to damage to the very small blood vessels of the kidney. So next. Now we have the thrombotic thrombocytopenic purpura. So it is commonly affected females at any age, but median age at diagnosis is 35 years old, so producing microvascular occlusive lesions with hyaline thrombi and endothelial proliferation throughout the body. So the thrombotic thrombocytopenic purpura, it is a rare disorder that causes blood clots or thrombi to form in small blood vessels throughout the body. So these clots can cause a serious medical problem if they block blood vessels and restrict blood flow to organs such as the brain, kidneys, and the heart. So next, last one, we have the disseminated intravascular coagulation, or the DIC. So DIC, it is a diffuse clotting in the vessel lumen due to extensive vascular damage or the release of thromboplastic material into the circulation that initiate the coagulation system with subsequent activation of the fibrinolytic system. So the DIC, it is a rare but serious condition that causes abnormal blood clotting throughout the body's blood vessels. So it is caused by another disease or condition such as an infection or injury that makes the body's normal blood clotting process become overactive. So next.
So we are still in the non-immune mediated, which is the hemolytic anemia associated with infection and toxic agents. So next, please. So the next non-immune mediated hemolytic anemia is the hemolytic anemia associated with infections. We know that there are good and bad bacteria that we encountered every day. A good bacteria, which is it can help our contribute in our body. The bad one the bad one, which is can cause illness or um, disease in our body. So this infection agent that are directly or indirectly responsible in the destruction of red blood cells are the malaria plasmodium parasite. The next one, Bartonella bacilliformis. Number 3, babiosis. Number 4, Mycoplasma pneumoniae. And the last one is the Clostridium perfringens. So these 5 are bacteria which is a bad bacteria that can cause destruction for our red blood cells that may lead to hemolytic anemia. So the next one, the next non-immune mediated in hemolytic anemia is the next slide. So the next non-immune mediated is associated with chemical agents. There are two: the agent hemolytic to normal cells and agent hemolytic to abnormal cells. So the first one is the agents hemolytic to normal cells. Distilled water, the first one, when used as irritating fluid during transurethral resection. Second one, the toluent, trinitrotoluent, nitrobenzene, acet, acet, acetanilide, and pinacetain is responsible for cyanosis. The third one is the toluent and trinitroluent, which may lead to aplastic anemia. The next one is the bromine, which makes blood turn chocolate brown, and the last one, the lead. The next slide. So the next chemical agents hemolytic to abnormal cells, the certain drugs and chemicals that have oxidizing activity may produce hemolytic anemia in individuals with this deficiency. The first, G6PD deficiency, which is discussed in the second part of the video, the glutathione deficiency, unstable HB, and the unstable or low glutathione level, the premature infants. Next slide. And the last, non-immune mediated, which is the hemolytic anemia associated with physical agents. There are four: the heat, traumatic hemolysis, cardiac vascular disease, and prosthesis, and March or stress hemoglobinuria. So the heat is the budding fragmentation of red cell membrane, microspherocytic. The next one, the traumatic hemolysis, the schizocytes, irregular contracted cells, or the triangular cells, or the helmet cells. The cardiac vascular disease and prosthesis, schizocytes, irregularly contracted cells, and the last one is stress hemoglobinuria, which passage of dark urine after exercise, abdominal and lower back pain. And the last one is the next slide, please. The hypersplenism, which is under the non-immune mediated. Next slide na. So this hypersplenism is an overactive in our spleen. So we know that spleen is an organ found in our upper side of the abdomen. So the spleen helps filter old and damaged cells from our bloodstream. So if our spleen is overactive, it removes the blood cells too early and too quickly. So this is seen in acquired form of extrinsic anemia, in which red cell sequestration in spleen is increased and resulting to their subsequent destruction. So this is the end of this report. Miss Aideen, please take place na po.
Okay, that would be all. And again, to sum up, the anemia, or the general term for the anemia that is associated with increased red cell destruction. So take note, it is the hemolytic anemia. So So when we say if we have a hemolytic anemia, so there is increased red cell destruction. And if we have increased red cell destruction, so our body would compensate it, or would act its compensatory mechanism by the bone marrow. So in order to compensate that loss of red blood cells, our bone marrow will accelerate its RBC production, and we can finally call it is hemolytic anemia when our bone marrow RBCs because of the blood cells. And again, this hemolytic anemia is subdivided into two: the intrinsic and extrinsic hemolytic anemia. So if we say intrinsic, meaning in or inside, so meaning the defects is within the RBCs. But when we say extrinsic, so the defects are on the outside or in the environment of the red blood cells. So again, in intrinsic, the RBCs are defected while the environment are normal or healthy, while in extrinsic, the RBCs are normal, but their environment is invaded with toxic agents or um, any external factors that can cause hemolysis. And under intrinsic, so it is mainly associated with hereditary, which are the membrane disorders, enzyme disorders, and hemoglobin disorders. And rare lang ang acquired, which is the membrane defect. But in extrinsic hemolytic anemia, it is mainly associated on acquired. And under that acquired, we have immune mediated and non-immune mediated. So I hope our discussion is clear to you and that we are able to deliver our objectives in this discussion. And we hope that you learned something from this discussion. And that would be all. Thank you.